Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is best practices for clean and compliant long-term care facilities. My name is Robin Malik, and I will be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Kley. Joined the Clorox company in 2018 as the Senior Infection Preventionist. Was a registered nurse and is board certified in infection control and epidemiology. She holds a bachelor's degree in microbiology and recently completed a master's degree in public health at the University of Nevada. Started her nursing career in long-term care and has done infection and control counseling in this setting. She has nearly 20 years of acute care infection prevention experience, having worked for several large healthcare systems. Doe's motto is, "Not on my watch." And with that, please welcome Kley.
Welcome, everyone. I'm so excited to present today on the best practices for a clean and compliant long-term care facility. In this webinar, the three primary objectives that we're going to tackle are the revised CMS requirements for long-term care, the basic principles of cleaning and disinfection, along with some of the associated challenges, and some tools to help you to have a clean and compliant facility. I'm particularly passionate about this topic of the new CMS regulations. I recently completed a master's degree in public health, and this was the topic of my thesis project. So let's go ahead and get started by providing some background as to why it was necessary for CMS to revise these requirements. I'm sure that you're all painfully aware that these changes go into full effect next month. So why are the new requirements important? Well, the elderly population in the U.S. is rapidly increasing. The first baby boomers turned 65 years of age in 2011, and by 2030, the number of persons aged 65 and older is expected to reach nearly 71 million, making up 20% of the U.S. population. That's 1 out of every 5 persons. According to the U.S. Department of Health and Human Services, most Americans over the age of 65 will need long-term care services at some point in their lives. In 2014, approximately 4.1 million people resided in the 15,000 plus long-term care facilities in this country. So as you can see, with the rising long-term care population comes a greater need for infection prevention in this setting. Unfortunately, infections are quite common in long-term care facilities. The CDC reports that somewhere between 1 to 3 million serious infections occurs in this setting every year. In addition to the pain and discomfort caused by these HAIs, the CDC reports that nearly 400,000 people die annually as a result. I spent 20 years in the hospital environment as an IP. I've seen firsthand the impact that these infections have on the individuals behind these numbers. The N of 1, as CDC's Dr. Julie Gerberding used to say. The sad truth is most of these infections are preventable through a well-planned infection prevention and control program. HAIs are a very real and complex problem for this population. The elderly are at higher risk for infection due to their frailty, waning immune system, the complexity of having multiple chronic conditions, prolonged healthcare stays, and overexposure to antibiotics. Having worked with the elderly population throughout my nursing career, I know just how fragile these folks can be. Unfortunately, true infection data is lacking for the long-term care population. Several studies cited here indicated that HAI rates in long-term care settings are similar to those in acute care settings, as shown in this graph. High HAI rates in the hospital were pretty much a daily occurrence when I was a hospital IP. So I was really surprised to learn that the infection rates are so similar between the two settings. I think this highlights the need for more data from long-term care. I'd like to point out that HAIs take up more resources and they add cost to an already stretched system. Not only are higher HAIs a problem, but evidence that thousands of outbreaks such as influenza, norovirus, and C. diff occur in long-term care each and every year. Regulations that enforce infection control really do help in reducing HAIs. So let's briefly review some of the other regulatory bodies. So CMS is not the only regulatory body for healthcare facilities. It's imperative that you're familiar with your state health codes. For example, New Jersey has a brand new law in response to the 2018 adenovirus outbreak that killed 11 children in a nursing rehab facility there. This law requires facilities to submit their outbreak response plans to the state health department. There may also be local or county level public health requirements. For example, some counties in California require healthcare workers who have declined the flu vaccine to wear a mask during the entire flu season, which typically runs from October through March. And then, of course, there's OSHA. OSHA includes the use of standard precautions, and it also spells out blood and body fluid spill cleanup measures. For states who have their own OSHA-approved plans, please note that the state plan does trump the federal plan in this instance. So now we're ready to take a closer look at the actual revisions to the CMS regulations, specifically for infection control in long-term care. CMS defines the purpose of infection control is to provide a safe, sanitary, and comfortable environment, and to help prevent the development and transmission of community diseases and infections. When this is done well, it translates to lives saved and a better quality of life for those we serve. Since the initiation of the three-phase implementation back in 2016, you're all likely familiar with Title 42 of the Code of Federal Regulations by now. Part 483.80 describes the infection control requirements. As previously mentioned, facilities participating in Medicare must be in full compliance with these new rules by the end of next month. Surveyors will be looking for compliance with these new regulations during their facility site visits. Facilities not in compliance with these regulations can be denied payment and may even be terminated from participation in Medicare or Medicaid. With more than half of its funding coming from CMS, facilities simply cannot afford to be non-compliant. I encourage you to read through the interpretive guidance at the link provided on this slide. So now I'm going to dive into some of the key requirements for a compliant infection control program. I'll only discuss Infection Preventionist or IP here, as the others will be addressed throughout the presentation. The requirement to have a designated IP is a new one. The facility must designate one or more individuals to be responsible for the infection prevention and control program. This individual must have primary professional training in isolation, medical technology, microbiology, epidemiology, or other related field. The IP is further required to be qualified by education, training, and experience or certification. CMS does encourage the IP to complete infection control training offered by the CDC. Also know that many health state departments offer acceptable training. I'd like to point out that the original wording of the revised regulation had stated that the IP must work at least part-time at the facility. But please know that as of July of this year, the wording has been changed to the IP must be allotted sufficient time to meet the objectives set forth in the facility's infection and control program. What this means for the facility is that someone must bear the title of IP, and the facility must determine how many FTEs or fraction of an FTE it will take to complete the work. Shown here are a few of the required policies for compliance prevention and control program. There's quite a few, so for the complete list of policies, please see the interpretive guidance at the link provided earlier. One of the most important policies for any infection prevention and control program is hand hygiene. After all, this is where all infection control begins, and it's well established that it's the single most important thing that we can do to prevent transmission. Two other very important policies are standard and transmission-based isolation precautions. The new CMS regulations require that the isolation be the least restrictive possible. In addition to duration of isolation precautions, be sure to include how and when to use these precautions. And don't forget to include the selection of and the proper donning and doffing of personal protective equipment, or PPE. Another very important policy is your cleaning and disinfection of environmental surfaces and shared medical equipment. So much of the medical equipment in long-term care is portable and moves from room to room. This policy is crucial and often overlooked. In fact, transmission of epidemiologically important pathogens, such as Candida auris, have been linked to failure to clean and disinfect portable equipment between each patient. And I do like to point out that our hands really are only as clean as the environment around us. Another is needed to address staff education and competency assessment. Infection control is one of the required competencies with the new regulation. I'll talk more about competency later. And don't forget residents and family members. It's now a requirement to have a policy on infection control for them as well. Some key elements of this policy would include hand hygiene and cough etiquette. As part of standard and transmission-based precautions, I now would like to take a few minutes to share what I know new enhanced barrier precautions, also referred to as enhanced standard precautions. This is an approach from the CDC designed specifically for nursing homes to prevent the spread of targeted MDROs. Please see the yellow box at the bottom of this slide. This guidance does not apply to acute or long acute care hospitals, nor does it replace contact precautions or other pathogens such as C. diff or virus. I think of it as falling somewhere between standard and contact precautions. It should be used for residents with a targeted pathogen when contact precautions do not apply, for example, colonized patients. It's also intended for all residents, regardless of their MDRO status, who have wounds requiring dressings and/or who have an indwelling medical device. Environmental hygiene is a very important component of enhanced barrier precautions, and this includes daily disinfection of areas where residents congregate, such as the dining room or activities areas. The rationale? Well, focusing only on residents with active infections fails the continued risk of silent transmission from residents colonized with these pathogens. Using enhanced barrier precautions, residents do not have to be restricted to their rooms or limited from participation in group activities. Enhanced barrier precautions expands the use of PPE beyond the typical standard precaution situations. Gown and gloves are required during specific high-contact resident activities, such as the ones shown here. An example of employing these precautions would be a resident known to be colonized with Candida auris. Signage should be posted at the entrance to the resident's room. Staff would don gown and gloves to enter the room unless they were planning to perform one of those high-contact activities or when precautions applies. If the resident has an open wound, it would need to be covered in order for that resident to attend activities in common areas. Also, the resident would need to perform hand hygiene before leaving their room. I strongly encourage you to listen in to the CDC's COCA call on this very topic next week on October 24th. I'm sure that we will all get a little more clarity on this new strategy. So now let's go to antimicrobial stewardship, or ASP requirements. The ASP program should include antibiotic use protocols, as well as systems for monitoring your antibiotic utilization. According to the CDC, antibiotics are some of the most commonly prescribed medications in long-term care, with somewhere between 50 to 70% of residents receiving an antibiotic over the course of any given year. What's most alarming is that 75% of those antibiotics are incorrectly prescribed. We all know that overuse of antibiotics leading driver of multi-drug resistance and C. diff infections. In a setting where nurses are heavily relied on for care decisions and where physicians are not routinely present on site, nurse education on antimicrobial stewardship is probably the more important in this setting than it is in any other healthcare setting. Our recommendations for meeting the requirement for an ASP include: 1, following the CDC's checklist. You can see the link provided in the yellow box slide. 2, compile an antibiotic utilization report for your quarterly QAPI committee, which should include the antibiotic therapy prescribed and the suspected infection being treated, which provider ordered the antibiotic, whether the order was a verbal order or if the physician physically assessed the patient and wrote the order on site. Finally, be sure to regularly share the facility's antibiogram provided by your contracted lab with your physicians and your nurses. Let's review some statistics on the current status of ASPs in this country. This survey, conducted by the NIH, Of 861 nursing homes, approximately 3/4 of them had a comprehensive ASP in place. While this is great, and it is an improvement over the survey 4 years earlier, this means that 1 out of every 4 long-term care facilities had a suboptimal ASP. We have to do better if we're going to win this war against multi-drug resistance in this country. One key finding from the survey was that nursing homes that had a certified infection preventionist were almost 5 times more likely to have a comprehensive ASP as compared to those without one. So if your facility, with its designated IP, you can expect a more robust antimicrobial stewardship program, which should translate to fewer MDROs and lower C. diff rates, as well as some potential cost savings. The authors of this NIH study highlighted several ASP challenges related to both resourcing and diagnoses shown here. These are 2 things to watch for as you develop your ASP. Now let's move on to important documents related to the required annual program review. Every infection prevention and control program needs to have these in place, regardless of setting. CMS requires that the facility conduct an annual review of its infection prevention and control program. The program is updated as national standards and guidelines change. Surveyors will expect to see this documented in the document shown on this slide. First, the infection prevention and control program evaluation. This ensures that all required elements are in place and also includes a review of the status of the prior year's goals. 2, the infection control risk assessment, which identifies infection control hazards to be focused on. Templates for a risk assessment can be found on both the CDC and the APIC websites. And then last is your infection control work plan. This plan uses the information gathered in the program evaluation and in the risk assessment, setting your goals and objectives for the coming year. And since you have shared patients with the hospital's community, one suggestion that I have is to collaborate with the hospital IPs in your area. Most have years of experience conducting program evals, risk assessments, and drafting infection control work plans. Perhaps they'd be willing to share their identified, of course, documents with you to use as a template for your own facility. The final requirement of the infection prevention and control program is process surveillance. This may be a new term for many. It's very important and it's often overlooked part of the infection prevention and control program. Process surveillance is essentially the review of practices, and in this case, infection control practices. The purpose is to identify whether staff are complying with the infection prevention and control policies. Much like we do HAI surveillance to identify trends and outbreaks, we do process surveillance to identify trends in our infection control processes. Some examples of process surveillance include monitoring of hand hygiene, isolation practices, use of PPE, and cleaning and disinfection practices. The data that's collected will provide actionable and measurable indicators for performance improvement. This data should be collected and reported along with other infection program data, such as your HAI rates, in your quarterly report to the QAPI committee. Data should never be collected just for the sake of collecting it. Rather, we need to respond to the data by taking action when appropriate. Such action might include staff education or even evaluation of new products. Please be sure to document any action taken. You know the nursing saying, not documented, not done. So we've spent a good amount of time talking about all of the new requirements. Now let's shift our focus to looking at some of the infection control challenges faced in long-term care. It's important to consider these challenges as your facility updates its processes and protocols to comply with the new CMS requirements. One of the most alarming and prevalent challenges in long-term care facilities is a general lack of resources, especially when compared to the acute care setting. This lack of resources includes staffing and funding. Frontline staff turnover is high, which makes it difficult to maintain an experienced and knowledgeable workforce. The current low unemployment rates also impact hiring, especially of nursing assistants who typically make only a few dollars above minimum wage for this very physically demanding role. Compounding the staffing issue is the need for many long-term care staff to wear multiple hats in order to manage the facility. For example, the director of nursing might also be the designated preventionist, while the assistant director of nursing might also be the director of staff development. Additionally, there are costs associated with running an infection prevention and control program, such as the required initial and ongoing training of infection preventionists and the staff. There are also supplies such as hand hygiene products and personal protective equipment. And there's the cost in time and resources to perform the various infection control activities. Together, these things affect the type and the extent of the infection control program that can be developed. Another challenge is that the facility is also the resident's home. Thus, we call them residents and not patients. A balance must be found between infection control and the resident's comfort. For example, CMS requires the least restrictive isolation measures possible that are based on the resident's ability and willingness to follow instructions. Interpretation of least restrictive is left to the individual facility's discretion. These potentially relaxed isolation practices, though, could result in pathogen transmission if not carried out properly. CMS also requires that group activities are offered to its residents. But not surprisingly, the risk of exposure and infection transmission is higher when people gather together in common areas, such as activities or dining halls. All of these challenges highlight the importance of a robust cleaning and disinfection program. Given the limited resources, it's not unrealistic to think that perhaps cleaning and disinfection could be compromised at times. The high rates of healthcare-associated infections and multi-drug resistant organisms in this setting certainly supports this line of thinking. In fact, several public health studies in recent years found that 80% of facilities had important gaps in their environmental cleaning program. The top gaps identified included a lack of training and documented competency to adhere to disinfectant IFUs, failure to audit cleaning practices, this would be an example of process surveillance, a lack of policies for cleaning medical equipment, particularly between residents, and even the use of cotton mops. Everyone should be using either microfiber or ready-to-use wipes in today's healthcare environment. With that, I think this is a great place for us to pivot to more practical content, and we'll first basic principles of infection control and cleaning and disinfection. It is very important for you to know which pathogens are most common in your setting and to target your cleaning and disinfection products accordingly. Shown here are just a few of the most common pathogens in long-term care settings. What are you seeing in your facility? Bloodborne pathogens, of course, compose a risk in any healthcare setting. And there have been several documented outbreaks of hepatitis B and C, specifically in long-term care settings, for failure to clean and disinfect glucometers between each resident. You must ensure that your disinfectant meets OSHA requirements for blood or body fluid spill cleanup. This means that the product should have kill claims for both HIV-1 and hepatitis B, or it should have a TB claim. Alternatively, a fresh solution of 1 to 10 bleach is also useful. Let's demonstrate now how these pathogens can be transmitted within a facility. Across the healthcare continuum, the one thing held in common is the chain of infection, which is made up of 6 different links. Each link must align in order for pathogens to be transmitted and for an infection to occur. Breaking this chain at any link can stop transmission and infections. As I review this chain, I want you to think about where your team can break it. Let's demonstrate the chain of infection using an outbreak scenario. In this particular outbreak, the infectious agent is norovirus. The reservoir in this outbreak is a kitchen worker we're going to call John, who came to work despite being ill. As a new employee, he was worried that he could lose his job if he called in, a phenomenon called presenteeism. John had been experiencing vomiting and diarrhea for the past 24 hours. He was not aware that he was infected with a communicable disease. While at work, John missed a hand hygiene opportunity after using the restroom. This resulted in the unfortunate contamination of the food he prepared that day. John is the reservoir in this outbreak. The portal of exit from John was both oral, the vomitus, and the diarrhea. The mode of transmission was indirect contact. through John's unclean hands to the food and then eventually to the residents. Our portal of entry for the residents was oral as they consumed the contaminated food. And the last link in the chain of infection is a susceptible host. As we've previously discussed, the elderly are very frail and susceptible to infections. The median attack rate for norovirus is typically 61%. In this 200-bed facility, 120 residents acquired norovirus infection. And note how many places designated by the red broken links that the infection chain can be broken through just hand hygiene, or environmental cleaning and disinfection, or better yet, both. That's 4 out of 6 of the links. It boggles my mind how HAI rates can remain so high when there are so many opportunities to stop transmission. If we focus on the environment in regards to pathogen transmission, there are 2 facts to consider. First, environmental surfaces and medical equipment harbor pathogens. Second, many, if not most, infectious diseases are transmitted by touch or contact. As shown in this image, there are 2 types of contact transmission. There's direct, which is person to person, and indirect, which is contaminated object or food, as in our outbreak scenario, to person. The bottom line is that environmental surfaces can be important reservoirs of pathogens. Hand hygiene and environmental cleaning and disinfection are key ways in which we can break this transmission. And this is worth saying again, our hands are only as clean as the environment around us. To further demonstrate how quickly pathogens can spread through a facility, let's review yet another. Let's walk through the details of this pre- and post-intervention study conducted in a 67-bed nursing home. Pre-intervention, a viral tracer was seeded onto the hands of 10 volunteers who then went about their duties as per routine. Just hours later, the viral tracer was found on almost half of the fomites throughout this facility, including in the entryway, the room, the nurse's station, team room, patient rooms, activity room, and even the shower room. Was introduced. This included education on the use of hand hygiene, gloves, and tissues for coughs and sneezes. It also included the provision of a disinfectant spray to the workers. This time around, the virus was found on only 32% of the items, which represents a 35% reduction in transmission. When you look at the data for both hand hygiene, or hands and fomites together, the reduction was a whopping 90%. So now that we see the importance of environmental hygiene, let's review the difference between cleaning, disinfection, sanitization, and sterilization. Lots of terminology to learn here. They all sound familiar, but the key differences are related to the level of microbial kill. Cleaning is simply the physical removal of dirt, organic material, while sanitizing is the reduction in pathogens to a level judged safe by public health requirements. For instance, the surface is now safe for food handling. Sanitization also applies to soft surfaces, privacy curtains. Disinfection, on the other hand, is the inactivation of almost all microorganisms. Now, we all know that in healthcare we often just say cleaning, but what we really mean is cleaning and disinfection. Last is sterilization, a process that leaves an object hypothetically free of all viable microorganisms. This is most commonly done with medical instruments such as those used in surgery. Please note that sterilants are not used on environmental surfaces, and sterilization, as you know, is rarely done in the long-term care setting. So with the basics of cleaning and disinfection behind us, let's focus now on some practical approaches to cleaning and disinfection. Shown here are the 5 steps for a cleaning and disinfection bundle. Let's go over each in a little more detail. The risk assessment, this should be your very first step in developing a cleaning and disinfection program. What is it? It's a proactive approach that considers the infection hazards that are most likely to occur and those hazards that would have the highest impact or severity should they occur. The purpose of the risk assessment is to help you in prioritizing and focusing your infection prevention efforts. Your cleaning and disinfection efforts. It's typically completed by an infection preventionist, but it's important that teams responsible for the environment, such as your EBS managers or directors, to also understand what it is and how it's completed. In fact, the process really should be multidisciplinary, and EVS should be represented at the table during the risk assessment. Here are just a few examples of things to consider when you're conducting your risk assessment. This includes things like, do we have the necessary or required policies in place? Are staff adhering to those policies? What are the prevalent or common pathogens for the setting? Do we have clear assignment of cleaning responsibilities? What about the education and training program? Do we know if our staff are competent? How do we know? Is competence documented? Shown here is a section of a risk assessment that I actually completed last year as part of my master's degree project that I mentioned earlier. It was a very collaborative process with a multidisciplinary team working together to complete it. This ensured that experiences and perceptions of other disciplines were included in the process. We modified a template that we had from the CDC website to better align with this setting. The template calculates the risk by multiplying the probability of the event occurring by the severity should the event occur. You can see the numerical value assigned to each potential in the column to the far right. This is used to guide your prioritization. In your work plan, please don't feel like you have to address every single item on the risk assessment. It's just simply not possible. Instead, prioritize based on those items with the highest risk. To showcase an example, facility where I did my master's project, upon performing process surveillance, we found that staff were not cleaning properly. The team agreed on a probability ranking for improper cleaning and disinfection as being likely to occur. They further agreed that the severity of frequent improper cleaning and disinfection could result in moderately poor outcomes. Therefore, they ranked the severity as having a moderate impact. Even though I think that we as a team rated this pretty conservatively, it still came out as a high-risk issue, as indicated by the risk score of 12 seen in the red. So proper cleaning and disinfection was definitely something that this facility included in their infection control plan for that coming year. And one final important note on the risk assessment, it does need to be completed no less than annually. So step 2 in our bundle is selection. This is key to any environmental cleaning and disinfection program, regardless of healthcare setting. Shown here are the properties of the ideal disinfectant. There are many things to consider, ranging from broad spectrum to safety. The information on this slide will help you to objectively evaluate products. Many ready-to-use wipes on the market today check most of these boxes. Taking a closer look at ease of use, ready-to-use products make the right thing to do the easy thing to do because there's little to no preparation. And looking more closely at cleaning properties, consider if the product is a one-step cleaner disinfectant versus a two-step product. There are many one-step products, including ready-to-use wipes, in today's market that are both a cleaner and a disinfectant. One-step products further simplify the cleaning process. Shown here is a multi-step framework to help guide the IP through the disinfection process. There are several key factors to consider, and these are healthcare relevant kill claims, kill times that are relatively short, less than product wetness, can it stay wet for the kill time having to be reapplied, and other important factors such as safety and ease of use. And because we get a lot of questions on wipes placement, I would like to point out that they really should be made available at the point of use to increase staff compliance with cleaning frequencies. And please note that keep out of reach of children does not apply to adults and the elderly. Rather, we need to use a risk versus benefits approach. Now let's take a closer look at relevant kill claims. This is a good reference chart that lists common infection types alongside their key causative agents. At a minimum, your disinfectant should list these pathogens. Remember that there might be multiple causative agents for any given infection. Take, for example, respiratory tract infections, which can be caused by either bacteria or viruses, or both. We're now ready for the third step in building our cleaning and disinfection program, which is to develop our procedures. These should be based on regulatory and accrediting body requirements such as CMS conditions of participation, or COPs, as discussed earlier in this presentation, state health codes, and standards from accreditation such as the Joint Commission. Your policy should be evidence-based and should probably consider the manufacturer's instructions, or IFUs. Policies should be general in nature and should include a purpose statement, scope, or to whom the policy applies, definitions of key terms, the general provisions such as setup, safety measures including PPE, and cleaning frequencies. And references should be provided at the very end. Procedures, on the other hand, are more the how-to, and they should be more specific, including the step-by-step cleaning. Provided here are some resources to help in your policies and procedures. For the sake of time, I won't review these now, but you'll be able to review them on your own later. Now let's shift gears a bit and talk about cleaning responsibility. These should be documented using a tool such as the grid shown here. This cleaning responsibility grid clearly identifies the who, what, when, and how of cleaning. We all know that if everyone is responsible, then no one is. This grid should be completed in collaboration with all relevant stakeholders to ensure both and agreement. With the ever-growing complexity of the healthcare environment, cleaning responsibility grid is a very useful tool to ensure that nothing gets overlooked. An eye-opening exercise that I encourage you to conduct at your facility is to take members of the multidisciplinary team into a given resident care area. Together, take an inventory of each piece of equipment and environmental surface in the room. Going item by item, ask them, who cleans this? When is it cleaned? How is it cleaned? You might be shocked to find out just how many items or surfaces are not being cleaned routinely, if at all. And like cleaning responsibility grids, standardized protocols are another important to reduce errors in cleaning. They also serve as helpful reminders for your seasoned staff. Be sure to work with your vendors, as they may already have protocols for you, or they may even be willing to assist in customizing one for you. Shown here are some examples of vendor-provided protocols for resident room cleaning. Okay, and now for step 4, disinfection bundle. Staff, education, training, and competency. Once you have your policies and procedures in place, you need to educate the staff who will be responsible to carry them out. It's really important that these policies are readily accessible and are shared with staff. You need to organize your training sessions. These should include both didactic or classroom session, as well as hands-on training. Again, competency must be assessed and it must be documented. At a minimum, training should be offered upon hire, as needed, such as when you put equipment in or a policy has been changed, and annually. So now let's focus more on the what of training. Here we look at a few good cleaning and practices to employ. Cleaning should be performed in a methodical manner, such as clockwise or counterclockwise around the room. When visible soiling is present, the surface must be cleaned first before disinfecting. This is if your disinfectant is a one-step product. The rationale for this is that organic material can reduce the efficacy of disinfectants. Cleaning with a detergent-based cleaner or using a cleaner disinfectant will help to remove soil. Also, when cleaning or wiping, always move from clean to dirty. The bathroom is always last, and the last surface cleaned in the bathroom should be the toilet. Always clean from high to low. In this way, dust or dirt that may have fallen below will be cleaned as you move downward. Finally, it's important to review the cleaning and care guides for your surfaces and for your equipment. Be sure to select disinfectants that are compatible with those surfaces. And note that high alcohol content present in some disinfectants can dry out certain surfaces, such as plastics, which can result in cracking and other damage faster than no or low alcohol disinfectants. With that, let's talk a bit more about equipment cleaning. It's important to ensure that equipment manuals are kept readily available. I am familiar with at least one online database that, with a subscription, houses all equipment manufacturer IFUs in one place. Equipment include the cleaning and disinfection instructions, and they can be many pages in length. So I've found that using Control F keyboard and entering a key search word such as cleaning will take you directly to the section with the cleaning and disinfection IFUs. Some equipment IFUs will list approved active ingredients, such as sodium hypochlorite, for example, while others may provide the disinfectant products by name. And since all disinfectants leave a residue, in order to extend the life of your costly equipment and surfaces, a best practice is to rinse after the contact time has been achieved. Alternatively, residue can be removed with a clean cloth. Let's talk about how to identify that staff are competent to perform cleaning and disinfection tasks. Recall that competency in infection control practices is one of the 10 CMS required competencies. This ensures staff understanding and tests both the knowledge and the skills of your workers. A competency-based assessment shows the employer how well a worker can perform a task and can consistently demonstrate the desired behaviors, whatever the situation. One of the best ways to do this is to assess the worker using the knowledge and skills learned in an on-the-job situation. But note that competency can be accomplished in many ways, as demonstrated on this slide. For example, if you've ever taken a CPR course, think about how many ways your instructor used to ensure that you were safe to perform CPR. You likely used each and every one of these methods. Hang in there, we're now ready for the final step in our cleaning program bundle, quality monitoring. How do we know that cleaning is thorough unless we assess it? Staff compliance with protocols can be monitored in a variety of ways. One way is through direct visualization. One way to accomplish this is through the use of a checklist, which can be used observing a staff member during the cleaning process or even after cleaning's been completed. While this method is quick, it's also very subjective. A more objective alternative is through the use of technology. Some of the most common methods include ATP testing or the use of fluorescent markers with blood. ATP testing should be performed shortly after the room's been cleaned. I recommend no longer than 1 hour after cleaning. It's a quick and indirect measure that detects an enzyme, ATP, in all living organisms on a surface, which can be from microorganisms or from other organic matter such as human skin cells. By measuring residual organic matter or bioburden, ATP measurement provides a good indication of the quality of cleaning. And note that since viruses do not have ATP enzyme, this method will not affect their presence. The other method is fluorescence. An invisible marker is applied to surfaces before cleaning. Removal of the marker is assessed after cleaning with the use of a black light. This method is easy, but it does take some time both before and after cleaning. It's important that you share the results with the EVS workers, as this feedback helps to improve the thoroughness of cleaning. Much like ATP, the fluorescent marker method does not measure the presence of microorganisms. And one last comment on the use of fluorescence. Researcher Claire and her team earlier this year found that metered or measured markers provide more consistent, standardized results. Also note that these technologies make great training tools for your EVS team. Finally, I'd like to make a few comments on environmental culturing. The CDC does not recommend this on a routine basis. Interpreting the results can be difficult without proper context, and it only at one point in time. Because we don't live in a sterile world, something inevitably is going to grow, and you're going to be left determining the significance of the result, as well as what action, if any, needs to be taken. Environmental culturing really should be reserved for outbreak situations, and only then after routine infection control measures have failed. So, we've learned that as the baby boomers continue to age, the need for long-term care services will increase greatly. In response, CMS has revised their regulations, including more robust infection control requirements. We learned some new terminology, process surveillance, and enhanced barrier precautions. We discussed some of the unique challenges that long-term care facilities face, such as staffing and funding-related issues, as well as the need to identify and address gaps in disinfection programs. We also reviewed some basic principles of both infection control and cleaning and disinfection, which included the pathogens of interest, the chain of infection, and the role of the environment in pathogen transmission. Finally, we covered the 5 steps for building a robust cleaning and disinfection program. These included risk assessment, product selection criteria, policies and protocol development, staff education and competency, and monitoring compliance. So with that, I'm now ready to take any questions that you might have.
Thank you so much for your presentation, Doe. We really appreciate it. We do have time for a few questions. The first one is, what's the number of infections in hospitals, since LTC isn't the only place having the issues?
Number of infections, it varies greatly. As you know, there are many different types of hospitals. There are rural hospitals, there are community hospitals, there are large teaching trauma centers. We do all in hospitals have to publicly report our infection rates, and the CDC does have that data. Unfortunately, there is no such data at this time for long-term care. I do suspect sometime in the future, probably the near future, that long-term care will also be required to report their infections up through NHSN as well.
All right, thanks. What does high frequency of cleaning and disinfecting mean? You give a little more specifics to that?
Yeah, it's going to be determined by the individual facility and through their policies. For the most part, cleaning should be conducted at least once every 24 hours. High touch surfaces, things like doorknobs, bed rails, walkers, those types of things should be cleaned more frequently. And then, of course, we need to clean anytime we think we have soiling or have contaminated a surface.
What solution do you recommend for insufficient staff to clean properly?
That is a tough one. I think my answer to that would have to be, it takes a village, right? If you have insufficient EVS staff, hopefully you're recruiting for more staff. But I think it's important. I think this highlights the importance of educating everyone else, from our assistants to our nurses. I mean, cleaning is not just EVS's responsibility. It's really everyone's responsibility. So I would say a team approach.
Okay, so someone asked what the name of the webinar presented by the CDC was that you referenced, and how we can access it.
The training is called Nursing Home Infection Preventionist Training Course, located on the CDC's Train website. It's free, no charge. It comes in several modules, so the IP it's probably going to take a little bit of time to get through all of those modules. You can think about completing a module a week or something. I wanted to say CMS does not require that you use the CDC's modules, but they do recommend. And as I mentioned in the webinar, that a lot of state health departments also offer similar training.
All right, thank you. The next question is, you mentioned a site to find cleaning requirements for different types of equipment. Can you share that as well, please?
The site I was thinking of is called OneSource. We commonly use it in hospital settings. I'm not sure what it costs, but there is a subscription. I want to say it's an annual fee. And you can find any IFU for any piece of equipment, anything from a surgical instrument on up in OneSource.
What is ATP testing?
So ATP stands for adenosine triphosphate. Adenosine triphosphate. It's an enzyme that's found in all living organisms, everything from humans, bacteria, to the vegetables you're growing in your garden. So ATP testing it's very simple. It's a meter. It looks a lot like a glucometer, and you have swabs, and you just swab a surface. We recommend high surfaces like your bed rails, your overbed table, that type of thing. And you stick your little swab in the meter, and it gives you an instant. And for example, the monitor that I was using at my last facility, the cutoff for what they called clean was 200 relative light units, or RLUs. If I got a reading below 200, then I could say that the EVS did a good job. If it was higher than that, we had some teaching to do.
And now for anyone interested in learning about the infection control products that Direct Supply offers, please help me in welcoming our fantastic product manager, product consultant, for our environmental solutions category here at Direct Supply, Karl Seagren.
Well, thank you, Robin, and thank you very much, Doe, for that great information. Lots of really good stuff there that I think all of our customers will be able to utilize right away. So I'm here to talk a little bit about some of the products that Direct Supply offers that can help with all of our customers, with their infection control and prevention program. The first, starting off there, we have a number of different products from lots of different popular brands, Clorox being preeminent among those. Clorox actually was kind enough to put together some products to simplify the process. Since there's so many different disinfectants out there, they put together essentially a senior living bundle that includes two products to simplify things. The first is Clorox Healthcare Fusion. This is a bleach-based cleaner disinfectant with a neutralizer that breaks down the bleach to minimize odor and residue and to eliminate the damage to surfaces that's commonly associated with bleach. It's able to provide the broad kill claims of bleach, including C. difficile in just 2 minutes, and norovirus and cold and flu in just 1 minute, without the harmful after effects. The second product is Clorox Healthcare Hydrogen Peroxide Cleaner Disinfectant Wipes. These offer kill claims as fast as 30 seconds, which make them the perfect product to use when time is of the essence. And it's a great tool to disinfect all those high-touch surfaces that you're finding throughout your communities. From today through November 30th of 2019, you will save 15% off your purchase price on these two products when you use coupon code Clorox15 at checkout as well. In addition to these great Clorox products, Direct Supply can also support you with additional innovative tools for infection prevention. As Doe noted, microfiber mops and cloths are fantastic tools to clean hard surfaces prior to disinfecting. And really, they are the way that we recommend 100% of the time throughout our communities. Not only do they excel at removing dirt, but they're also great at removing microorganisms. And we have a great assortment of these types of products from companies like Rubbermaid, a Direct Supply private label brand, and our newest supplier, Perfect Clean. While all three of these brands offer significantly more microbe removal than traditional cotton mops and cloths, Perfect Clean, which is represented here in front of me, is the only product with a patented built-in antimicrobial that prohibits growth on the textile. Perfect Clean has also come out with a really cool new product called the C-Pull that is intended to reduce hand-to-curtain contamination. So I have here a lovely privacy curtain and the C-Pull, which is this white and red device. This device is clamped onto a privacy curtain to provide a targeted hard surface touch point for caregivers and family members, and it's something that can easily be disinfected just like any hard surface. So it provides a nice additional solution in your infection control and prevention programs. Another innovative tool that will help with everything from daily disinfection to terminal cleans is the EviClean system. It features two things: dilutable chlorine-based tablets and an electrostatic sprayer that give you an efficient, touchless, no-rinse disinfection of virtually all hard surfaces, including those hard-to-reach areas that may be missed with traditional cleaning methods. The chlorine tablets are easily dilutable in standard tap water, and they offer kill claims for all of the most common microorganisms faced in senior living, including C. diff. Last but not least, we carry all of the janitorial supplies, including paper products, soaps and sanitizers, can liners, and personal protective equipment that you need to run a successful infection prevention and control program. Should you have any needs or questions, please contact your account manager with those, and please don't forget to take advantage of that 15% off coupon on the Clorox products through the end of November. Thank you very much for joining us today.
All right, thank you so much, Karl, and thank you to Doe again for your time today. If you have any questions about the products discussed, please email us at webinars@directsupply.com. And for more information about upcoming webinars, please visit directsupply.com/webinars. Once again, thank you for attending today.